There's a question on the Dopplers. What do you do if you find a monophasic pulse? Um, the answer to that is, as the answer to most questions, it depends. You should view a monophasic pulse as like your fire alarm going off in your house. It should very definitely concentrate your entire attention, and it should very definitely be looked into to find out what is going on. Having said that, it's not an automatic referral, in my opinion. What we are looking for with a monophasic pulse, what that is indicating is either severe arteriosclerosis, which you will remember is where the arteries themselves harden, or atherosclerosis, where there are plaques on the insides of the arteries which are blocking the blood flow getting down. Easy way to remember that. Atherosclerosis with the H, which if you look at a capital H, it looks like a blood vessel with a blockage. If that is the case, then there will be substantial other symptoms. If you have got poor enough circulation to make a legitimate monophasic pulse, there will be lots of other things to see. The classic mnemonic for this is the 6 Ps. The first P is pain. This is not just random pain. If it's plantar fasciitis or a corn, that's not a symptom of ischemia. We're talking about the pain caused by ischemia, the pain caused by a lack of blood to a muscle. It is usually in the calf muscle, and it will come in one of 2 flavours. Intermittent claudication is where you have pain after walking a certain distance. So you will load the muscle a certain amount, and then after, for example, 200 yards, the muscle has used all the available oxygen and the blood is not getting new oxygen down there fast enough. So there will be a predictable failure and a predictable point at which the muscle becomes painful. The slightly more serious version of that would be rest pain, which is where you get pain in bed at night because the blood cannot get enough oxygen into the muscle just to sustain it. Remember, when you're at night time, you're lying down, which means that the blood doesn't have gravity to help it. And so classically you'll get people will wake up in the night with calf pain, which is relieved by dangling the leg over the side of the bed. When you do that, the blood rushes into it and the pain is relieved. That is more serious. So the first P, pain, is to do with the muscle not having enough oxygen. The second one is pallor. If the limb is ischemic, it will most likely be very, very pale or even whitish. And you can test that as well by elevating the leg. With a healthy leg, when you lift the leg up in the air when the patient is lying down flat, it shouldn't change colour because the blood should be more than capable of pumping uphill. If you've got ischemia, however, you lift the leg up, the heart isn't capable of pumping the blood uphill. That should be a very definite warning sign. Paralysis, the loss of the ability to move, that would be in very severe cases. Pulselessness, which is kind of what we're looking at with the monophasic. Paresthesia, sometimes you will get the pins and needles. To say, anyone who's ever sat cross-legged and had their leg go to sleep knows about that one. That can be a sign. And perishing cold. Ischemic limbs have a tendency to be cold, although bizarrely sometimes they're not. So that's the classic presentation for ischemia in a limb, the 6 Ps. However, that misses out what for me is the most important and telling one, and that is the changes that you get to the skin. If you have an ischemic foot, there are certain things that you will not have. First thing that happens when you lose circulation is you lose the hair. So if somebody looks like a hobbit and they've got very, very hairy toes, it is exceedingly unlikely that they will have ischemia. If you have ischemia, the skin will not be nice and pink and well hydrated and robust. It will be dry, dusty looking, fragile, sometimes swollen like a sausage skin. It won't look like normal healthy skin. and the nails will be dystrophic. If you have ischemia, you will not have that nice well-shaped, well-formed nail plate that you can see through. It will be loose, it will be crumbly, it will have all of those symptoms going on as well. So you've got a whole raft of danger signs. There's a whole lot of things that will happen when you have an ischemic limb, of which a monophasic pulse is only one of them. Now, you have to treat these things in totality. You can't just look at one thing and over focus on it. As tempting as it is when we've got our new shiny Doppler and our new shiny skills to focus on that, if you've got a monophasic pulse and the skin is pink and healthy and the nails are good and the toes are hairy and the foot is warm and the patient reports no pain or anything like that, it is more likely that the problem is measurement error. You might just be having a hard time finding a pulse. I'm not brilliant at finding pulses, so for me that's quite often the case. If, however, you have got those symptoms, you've got the thin skin, the dystrophic nails, pallor, pulses, perishing cold, all of that, and a monophasic pulse, then yes, that's a hard refer with prejudice. So the analogy I like is, as I said, consider a monophasic pulse to be like your fire alarm. When your fire alarm goes off in your house, you don't immediately rush out and call the fire brigade, because the likelihood is somebody's making toast. So what you do definitely do is you don't ignore it. You go into the kitchen, you find out if somebody's making toast, you sniff to see if you can smell smoke, you check all the rooms in the house. You look for the other signs of there being a fire in your house. Ischemia is like a fire in your house. If it's there, you'll know about it. The alarm is just there to get your attention. And to extend that analogy further, if the fire alarm keeps going off, if you can only get a monophasic pulse and you can't find anything else, you still need to sort of look into it. So that might be a good opportunity to refer not to the GP to say this patient's leg's about to go blue and drop off, but maybe to a more experienced colleague to say, look, it looks all right, but I can only get a monophasic pulse. Would you mind having a look? So just like with dermatology, a referral upwards doesn't always have to go straight up to there. You don't have to go straight from podiatrist or FHP to a vascular consultant. If the danger signs are there, do that. But if the danger signs aren't there, if it's just a monophasic pulse in the absence of everything else, just refer to a more experienced foot health or podiatry colleague, see if they can find a pulse. All right, hope that helps.